All right, well, welcome everybody who is logging on for this Distinguished Speaker Series. I'm Jennifer Villock. I'm a professor in the Department of Otolaryngology, Head and Neck Surgery, and it is my great pleasure to introduce today Dr. Bruce Biccard. He is the Nuffield Professor of Anaesthetic Science at the University of Oxford. His research interests include perioperative medicine, perioperative outcomes, and global surgery. He is a huge proponent of international collaborative research, and his collaborations include with the African Perioperative Research Group, which has delivered the African Surgical Outcomes Study, as well as the ASOS, which is the African Surgical Outcomes Study 2 trial, African COVID-19 Critical Care Outcomes Study, the African Surgical Outcomes Study in pediatric patients, and the African Critical Illness Outcomes Study. He is the co-lead for the NIHR Global Health Group on Perioperative and Critical Care. He is also a National Research Foundation A-rated scientist. And if you're interested, Bruce has also published a book entitled Safer Surgery for Africa, Challenges and Solutions. And so today he will be giving us a presentation that is entitled Surgery and Anaesthesia in Africa. Before I turn the mic over to him completely, I do want to make sure everyone is aware of some housekeeping notes. So this webinar is being recorded and it will be available to view from the UH Research and Education Institution website. Don't forget to mute your microphone throughout the presentation. If you need technical assistance, you can contact the research and education team. Those folks are on the call right now. That's Nicole Bollinger or Abigail Zona Patel. If you want to ask questions, please type them into the chat. These questions can be seen by all attendees, and you also have the option to submit them anonymously if you prefer. And then of note, there are some who have been invited to the meet and greet session after the presentation. If that is you, please remain on the Zoom after the completion of the question and answer part. And with that, I will turn things over to Dr. Biccard.
Thank you, Jennifer, and thanks to Yi and Sam and others for this kind invitation, and also to all the Cleveland colleagues. It's a real pleasure to be here, well, this morning for you and this afternoon for me. So I'm going to present some work on surgery and anesthesia in Africa. My disclosures are pretty much all this work that I'm going to discuss is investigator-initiated and led, and these are the organizations that have supported our work. The presentation's really in three parts. The first is a short story of my research life and some lessons I've learned, the current state of surgery and anesthesia in Africa, and then what I consider the three pillars for addressing the challenges in low-resource environments to make things safer. Mainly, the work I'm going to present has been conducted by the African Perioperative Research Group, or APORG. This is a group which has developed probably over the last 10 years or so, and now includes representation from over 40 countries in Africa, nearly 1,200 hospitals, and nearly 2,000 clinician investigators. And I think what's really important to understand is these are clinicians working normal days who contribute to the work that you're going to see, and essentially the work is pretty much unfunded. These are the main outputs from the African Perioperative Research Group. And so some really impactful work on what's happening in surgery and anesthesia in Africa. And if you look at the group over these sort of 10 years, or nearly 10 years, recruited nearly 72,000 patients or participants with pretty much zero funding. I'm just going to give you a bit of an idea of how we got here and sort of a bit of an idea of me. So I think I've always been a nerd and wanted to know, do do research and want to know what's going on. And I think the most impactful thing for me at the beginning was this series in the Lancet on increasing the impact of your research and reducing waste. I think that in a low resource environment, this is super important. Um, at the time when I was in South Africa, I was keen on research, but the reality is there were lots of us doing small projects with little impact. And our feeling is the only way we can do decent research is to work collaboratively on important projects. And so what we did is we built a coalition. And it started off as a South African Perioperative Research Group. And when I heard Rupert Pearce present the USOS study, the European Surgical Outcome Study, I thought there's a very pragmatic research model which we can use in South Africa, and we can use it to galvanize people and get people to work together on something meaningful. And that was the first project we did in South Africa as a group. And it was a South African surgical outcome study. And what we did as well is we agreed on research priorities for South Africa in the perioperative space, and we followed the principles of the James Lind Alliance. And so we got 10 research priorities, and we started to address them. And I'm going to show you from that point what the top two were. And this has got importance a bit later in in the talk. But in South Africa, the top two were like national databases of critical care outcomes and BNP for a stratification for non-cardiac surgery. At the same time, we tried to grow the network outside of South Africa and across Africa, and that became the African Perioperative Research Group. And the first big project was the ASOS, the African Surgical Outcome Study. And what happened, yeah, this was through the generosity of Rupert Pearce. He shared his protocol, and this led to ASOS. And sadly, what we found is that if you have surgery in Africa, you're twice as likely to die than if you have surgery elsewhere in the world. Very simple message and a very sad message. But I think the most powerful thing we learned in that experience was that people care. People responded very positively to the message, and that there's work to be done to make surgery safer. As opposed to pointing fingers and suggesting that there were problems with the system or the people, it was more, what can we do to make surgery safe in Africa? I think this galvanized the group. And so what we did then as African Perioperative Research Group was let's determine what the research priorities are for Africa. And I think the biggest learning here was that research priorities or priorities are context sensitive. So look how different these top two research priorities are compared to what we saw in South Africa. So here it's about developing training standards for perioperative care and minimum provision of care standards. Now, these are things which have been around for well in excess of 50 years. And yet these are the most important priorities for African clinicians. And that tells you the disparity between a low resource environment and a well-resourced environment. So the next thing I think is you have to be responsive to the signals. So from ASOS, we saw that you're twice as likely to die if you have surgery in Africa, and you need to respond to it. And so we set about responding to the signal of harm, and that was by interventional trial. But to do something in a low resource environment, you need to challenge conventions. And now I have been participating in international collaborative research with PJ Devereux, for example, from McMaster. And these are really data-dense collaborative efforts, but in a low resource environment, you can't do that. And so we suggested that to respond to this increased mortality, we just need a very simple pragmatic trial. And the real problem is that in Africa, we have too few human resources. So we know from the Lancet Commission, you need 20 to 40 specialists per 100,000. That's surgeons, anesthetists, obstetricians. And we know from ASOS that there's less than one per 100,000. And so we suggested like a novel study design in a cluster randomized trial of hospitals. And the only objective outcome that we could have, which didn't cost anything, was mortality. So patients were either alive or dead. But as soon as you pick something like mortality, which is fairly infrequent, even in Africa, at 2% in the perioperative period, the numbers just exploded. And so if you want to show 25% relative risk reduction, you need about 60,000 patients. So we set about doing this. So this was a trial of increased postoperative surveillance because we saw from ASOS that patients were dying from failure to rescue in the post-op period. And we needed to randomize about 65,000 patients. Massive effort across Africa. We got to nearly 30,000 patients, and then COVID hit, and eventually we had to stop the trial because it was too complicated with exposing patients and exposing clinicians unnecessarily to each other to do the trial. And so we stopped at about 30,000 patients, and we failed. I mean, this was pretty devastating. It was a massive amount of work. But you can see either way, whichever way you look at it, we made absolutely no difference to the outcome for the surgical patients. And I think the most important thing is you have to understand what you did and what happened. So fortunately, we had a process evaluation and background of this trial. So here's our program theory for the trial. So we knew in Africa that failure to rescue is a big problem. That is death following complications. And so we thought, if you can identify high-risk patients, then you could increase postoperative surveillance, you would spot the complications earlier, you could escalate therapy appropriately, and you'd decrease mortality. That was the program theory. The reality is we don't actually know what happened in that complex postoperative surgical environment. And we learned that through the process evaluation, that there are a number of factors which were impacting on this program theory and what was being delivered. It had to do with resources, had to do with people, with teamwork, with leadership. There are all sorts of factors which contribute to the outcome. I think what happened as well is that when you start doing this, you see so many opportunities to improve patients' outcomes. And these opportunities, I think, take a long time to generate the evidence to demonstrate that they work. So what I did was I wrote down what I thought contributes to increasing patient safety in the perioperative space in Africa. And I've put this in this book, Safer Surgery for Africa. And the idea is I would prefer that people try some of these things that I think might make a difference and start a discussion while we as clinician scientists try to provide the evidence that these things either work or don't work. So let's look at the challenges in Africa. I think these are the big questions. Who gets surgery and who provides it? What surgery is provided? when does the surgery happen? And when and how do patients die? So what I'm going to do is I'm going to show you what we know from the work that's been done by Apple. So who gets surgery in Africa? In Africa, patients are young and fit. They've got a mean age of 38, and half of the patients are ASA class 1. If you compare that to the UK, so this is work from the most recent national audit project, you can see in the UK, average patient population, sorry, the average age is about 52, and only about a quarter of the patients are ASA1. So very different risk profile. Yet, in unadjusted outcomes, you're twice as likely to die if you have surgery in Africa. Who provides the surgery and anesthesia? So it looks like this. In adults, about half of the surgery is provided by non-specialist surgeons. And when you look at pediatric surgery, about 4 out of 5 surgeons are specialists. But the scary thing is when you compare it to the anesthesia providers. So you can see for every category, there are less equivalent trained anesthetists. And this has implications because there's a lot of people who advocate for, ways of providing sedation for surgery to ensure that surgery can happen if there are no anesthetists. And we looked at this in the African data, and we looked at non-physicians providing sedation for adult surgery and physicians. And what you see is that severe complications and deaths are over 10% when it's a non-physician and down at about 2% when it's a physician. The interesting thing is when you try and look at the environments of the two, what you find is that they're incomparable. So the non-physicians are providing sedation to allow surgery because there's either no facilities to provide general anesthesia, and also there are very few or little supervision. And so they're put into a very precarious position to provide sedation to allow surgery. So I think, when you say or you do research and you can show that there's no difference in outcome um, between a non-physician providing sedation and a physician, where the research is done in a well-resourced environment where there's adequate support. It's not the case in a low-resource environment, and it's extremely dangerous, in fact. What surgery is provided? So the interesting thing is that cesarean sections absolutely swamp the type of surgery. So a third of all adult surgeries in Africa are cesarean sections. And then in beads, it's about a quarter GID. And then all these subspecialties like cardiothoracic, hepatobiliary, neurosurgery, ENT, vascular, they less than 5% of the surgeries. And if you look at the volume of surgery, so Lancet Commission reckons we need about 5,000 cases per 100,000 population. And in the UK, it's about 8,500 per 100,000 population. In Africa, it's about 600. So you need 8 times more surgery in Africa at the moment than is currently provided. I'm going to take you back to cesarean sections because I told you about a third of all surgeries in Africa are cesarean sections. So if you want safe maternal health, you need to be able to provide nearly 20 cesarean deliveries per 100 live births. In Africa, it's in the area of about 6 to 8 cesarean deliveries per 100 live births. So the implications are, even though obstetrics or cesarean deliveries are the most common surgical procedure, we still need 2 to 3 times more cesarean sections. So then it's not surprising when you start to look at other types of surgery like cancer. We need at least 4 times more cancer surgeries in Africa. And then when you look at other those subspecialty surgeries, are essentially neglected, neurosurgery, etc. You need over 20 times more to be able to provide a decent surgical service. What's it like where individuals are giving anesthesia and providing surgery in Africa? So if you look at the theatre safety, in SR Speed, what we did is we asked the surgeons and the anaesthetists to tell us if they thought the operating room was safe. And so this is the anaesthetist and the surgeon in agreement. So for the neonates, 1 and 2 pairs of anaesthetists and surgeons said that the theatre they were working in was unsafe. 1 and 3 thought the theatre was unsafe for infant surgery, and 1 and 5 thought that theatre was unsafe for children under 6. And that's quite startling. And when you look at, practices to ensure safety, checklists are only used in about half of all cases in Africa. And I do believe that a big component of this is that they are not necessarily context sensitive. In other words, the questions in the checklist which are redundant, which if you don't have them or you can't answer in the affirmative, they just become a distraction. And the interesting thing is when you look at the checklists and you look at their provision in emergency surgery, their use drops off. And I think that um, reiterates the point that as things become more dire, that the use of the checklist drops because of the redundancy in some of the questions. The ability to provide essential emergency and critical care. Now, this is like the most simple stuff. This is like airway and lines, etc. When you look at the different domains for it, you can see that the resources available in the hospitals are really limited. So this was from the African Critical Illness Outcome Study, which is a point prevalence study across hospitals across Africa, looking at all the patients in the hospital on a single day. And what you see is that with training, it's only 2 out of 10 hospitals actually had the adequate resources that are recommended for these most basic emergency and critical care. And the most commonly available was human resources at 7 out of 10 hospitals. And so this is a big problem in providing resuscitation. When does surgery happen? Most surgery in adults is emergency. About 3 out of 5 cases are emergent, and in kids, about 2 out of 5. And when do the patients die? Well, the majority die postoperatively. Adults, 95% die on the ward. Kids, nearly 90% are dying on the ward. And most of these deaths follow gastrointestinal surgery. I think it's important to consider how these patients die. So we know, I'm going to talk a bit about the complications, emergency resuscitation, failure to rescue in the facility. So from a complications perspective, we know in adults that 20% of the deaths are associated with bloodstream infections and deep surgical site infections. This is the most common cause. And in mothers, it's obstetric hemorrhage. Nearly half of the mothers die from hemorrhage. And then the second largest population attributable risk for death in mothers is anesthetic complications. If you look at the critical incidence in Africa, so this is also unpublished work, On the left is the apricot, and on the right is Assos beads. But what you see is the dominance of the blue bars with the critical incidence. And with kids in Africa, a lot of the critical incidents are sort of in the respiratory group. And I think what's happening is a lot of these pediatric critical incidents are associated with airway problems and subsequent death, unfortunately. And if you look at resuscitation of critically ill surgical patients, again from ACIOS, when we did the point prevalence study across Africa, what we saw is that of all the critical ill patients, only 1 in 10 was receiving adequate essential emergency and critical care. And then if you look at the different types or components of critical illness, 1 in 2 were appropriately managed for a decreased level of consciousness, and similarly for cardiovascular failure, and about 2 out of 5 for respiratory failure. So, I mean, it's a complicated environment, and it's certainly impacted by the resources which are available. If you look at obstetric hemorrhage, what we know from Africa is that a lot of the preventative therapeutic and organizational measures are not currently applied for managing obstetric hemorrhage. There's limited availability of some of the uterotonics, tranexamic acid, and blood component therapy. And then of the feasible interventions, so these feasible were determined by a consensus group across Africa. 5 out of the 6 feasible interventions are unavailable because the human workforce is unable to provide them. So what's the consequence of all of this? Well, this is what it looks like. If you're adult in Africa, your risk for failure to rescue is twice the global average. If you're a mother, it's 17 times higher than high-income countries, in fact, 17 times higher than the US. And the kids are 4 times higher than high-income countries. The higher failure to rescue in mothers and in children is because the factors leading to death are more acute than in adults. So deaths in mothers is hemorrhage. Deaths in pediatrics, we haven't done all analyses yet, but it would suggest that the acute deaths associated with the airway and with arrhythmias, whereas in adults it's infections which give you days to respond, and hence the failure to rescue is not as high as the other two. What about the facility? So we've spoken a lot about the resources that are available, and when you look at the attributable risk, what we find is that about 30% of mortality of this is Assos beads of pediatric surgical patients are tied up in the facility, and about 17% associated with the country. So if you have a look at this, the variance in the contribution to pediatric deaths, about 15% is the country, 15% is a hospital, and 15% is a facility. About, let's say, 25% are the surgical factors and about 30% the patient factors. So nearly half of the variance in mortality is associated in the context in which surgery and anesthesia is provided. So I'm going to sum up now what surgery looks like in Africa. In Africa, we have young, fit patients, but we have many providers who thrust into unacceptable scenarios to enable surgery, especially when anesthesia is not possible. We provide care for only some surgeries in Africa, with many specialty surgeries are being neglected. And I think this means there's a huge unacceptable invisible mortality. And there's also excess mortality in these specialty surgeries. The next thing is that the environment is often unsafe for surgery. And there's really a paucity of safety mechanisms to protect both the clinician and their patients. Most patients are dying on the post-op ward, but in kids, there's also a significant burden of death on the day of surgery. So you saw about 12% of the patients or pediatric patients are dying on the day of surgery. We certainly know what complications are predominantly associated with death, but there's definitely an inadequate provision of emergency resuscitation and resources. And the result is there's failure to rescue, there's excess death. And this context or this surgical environment is probably contributing about 50% to the mortality of the patient. And this is not just an African problem. And so this is a recently published Latin American surgical outcome study, very similar findings to what we've seen in Africa. High perioperative mortality rate, high failure to rescue, similar complications. So what are the solutions? As I said, I'd put down my thoughts in this book, and I think there are three pillars. So the first is what I've called the inside-out model of quality improvement. And so what we saw from the process evaluation in ASOS 2, that there are a number of factors which determine how people or environments behave in this perioperative space. So the model works on the principle that you have to go from the inside to the outside. So each successive step is determined by the prior step. So the first thing is you have to have a program theory that is consistent with the beliefs and values of the individuals who are doing the work. So if they have other priorities, you're going to fail at the outset. Then you need a knowledge and education to explain your program theory. You need an intervention which is deliverable. In other words, it can't have lots of steps. It's going to be very simple. You need processes that you track, that you can report back to the team that this is happening well, this is not happening well, this is what we need to do. And then finally, no matter how good you are in providing this model of quality improvement, the limiting ceiling will be the resources that you have available. And this whole model is based on communication through all the steps. So the second pillar, I think, then is what I call the outside-in model, because we know that no matter how good you are inside the hospital or the perioperative space, your ceiling is going to be the resources. So you can increase your processes and make them beautiful, but you're not going to succeed in improving it beyond a certain step if you don't address the resources from the outside. And I think the third pillar is advocacy. So I think it's really important to address these problems with politicians. They need to be accountable for what is happening to the population. And the community needs to be empowered as well. They need to know that it's not acceptable for their mothers to die in surgery, for example. Providing the education for the community will provide a voice for advocacy as well, which I think is important. Finally, I think in all the work we've done, what we realized is that this 50% of mortality lies in the context or the surgical environment. And so to understand this is the next step we're going to undertake. It's going to be a continental audit project. It'll be modeled along the principles of the NHS UK national audit projects. And what we're going to do is we're going to do this for perioperative death across Africa to try and understand the main reasons or causes for death in the perioperative space in Africa. So I think in summary, we've got a very good understanding now of what surgery looks like in Africa. And I think while we try to generate evidence for interventions which work, there are things that we can do as a global community to improve surgical care in Africa in the interim. Thank you.
Are some questions that are coming in through the chat. One question here is related to training, and this person notes that training can decay over time, especially when the key components of that training are not continually enforced. And so they're wondering, do you see a role for artificial intelligence potentially on clinicians' phones at bedside as a way to reinforce training and assist with some of the clinical decision making that may need to be optimized in these scenarios?
Yes, absolutely. So I think the one thing that we have seen in Africa is that training is a problem, and also mobile technology is amazing. Um, and so, yes, creating almost like communities of practice, where even though clinicians aren't close physically, they can be close through mobile technology. They can share information with that, and also, yes, creating a structure where there is support. Uh, checklists and that sort of decision aids through mobile technology. Yes, I think there's a big opportunity there to provide an environment which is safer.
Mhm. And if I can ask a follow-up question to that, do you see I know your presentation today really focused heavily on the work in Africa, but I know that a lot of these are global initiatives spanning multiple different continents. Do you see similarities in some of the workarounds that folks in different geographic areas that are low resource are using? For example, maybe in the United States or the UK, this particular tool would be used, but it's not widely available. So there are different kind of downstream options, and how is that information shared across different groups to try to optimize what folks are able to do?
So I do think lots of people are probably looking at workarounds which are similar in philosophy. I don't feel that we've organized ourselves well enough that we're sharing in like a global community on what people are doing. So my feeling is I've been fortunate to see some workarounds that people have been doing in different environments, and I've also been fortunate having been here now in the UK and seeing what some people are doing. And the reality is they're definitely transferable, but we're not communicating them. So it would be nice. I'm not sure how we're going to do this, but we do need to create a community where people are willing to chat and discuss how they're seeing things to see if we can expedite this sort of a global change in how we approach education, approach managing failure to rescue, communicating with patients. There's so many things. And I think, with mobile technology and apps, it's this huge opportunity to make a quick change.
And some additional questions include, how is the landscape of medical legal processes evolving as surgical capacity increases, but we still have these higher mortality rates and complication rates?
Um, it's a difficult question. Um, I suppose it's difficult, firstly, because I can only speak from a African perspective, and I don't feel I have the knowledge of the different countries' medical legal systems across Africa. Um, but one thing is I think one thing which is quite clear from my experience of working in South Africa with the medical legal system there is how it's almost curtailing some of the surgical provision which is provided. For example, obstetrics has become a really big area of medical legal litigation to the point that I think some people will not practice, particularly in obstetrics. And that's got huge implications for being able to provide um, essential surgery. Uh, so I don't know what it's like in other African countries, but I think the medical legal question is a really complicated one, and it's not assisting us in increasing access to surgery and trying to make surgery safer, in my opinion.
Additional questions include how would you envision the best way to bring together a global perioperative community? And I guess one of the questions embedded here is, do you think that the longstanding kind of grassroots organization that you've been a part of and built is sufficient, or do you view a role for getting, for example, other professional societies, World Health Organization also involved, or does that just add layers of bureaucracy?
No, I th I think what one has to do is first show that some of the problems are universal. Um, if you know this, I think the strength of work is okay. I'm going to take a step back. My my philosophy is the best way we can make big change is to address generalizable problems. And so we have to demonstrate that some of the things are generalizable, and hence we can have solutions which address those. I think that's why the work from the Latin American group is really good, because it shows that they have similar problems to what have been demonstrated in Africa, which means then that we can have a similar strategy for quick wins to make surgery and anesthesia safer. So if we can generate enough evidence from different regions that they got similar problems, I think then makes it much easier to work together as a group. I think you touched on another really important is that I can't remember your words, the regulatory barriers to working together. I think one of the real successes of the African Perioperative Research Group is that it was a group of clinician researchers, and it was built totally on trust. And that's been very powerful in enabling the group to do work. And the interesting thing is, over time, ministries of health have started to contribute and support the work that's been done.
Great. And maybe we have time for two more quick questions. One of which is about how often are clean and sterile disposable supplies not available, which hopefully can be a quicker answer. And then maybe closing thoughts on how clinicians can better influence governance.
Okay, so the disposables aren't well, single-use disposables are, in my opinion, hardly ever used as single use. They're re-cleaned and re-sterilized and reused. So disposables are, yeah, it's a difficult space, and that brings in the whole question of um, green anesthesia, green surgery. I think there are lots of unknowns in that space on which is the way to go, but a large proportion of equipment is reusable equipment. So I think your clinical environment is really different to a low resource environment. And I've noticed it with my move just from South Africa to the UK, how different it is. It's really different. And then the second question was
Yep.
government.
How can clinicians better influence governance?
Governments. Sorry, did you say governments, Jennifer?
This, and I guess the heart of the question is how do we be better advocates?
So I honestly think the best thing we can do is help communities understand what's happening to their family and friends in the perioperative space. Um, until that happens, the communities will not hold the governments accountable for the outcomes that are happening. If our voices are really tiny in moving governments, I think for me, the most powerful thing I've ever seen was was a treatment action campaign in South Africa when antiretrovirals were not provided to HIV patients, sort of in the early 90s. Sorry, late 90s. Um, Through community education and solidarity, they managed to change the government. And I think that's where we have to go. We have to spend more time with our communities, educating them what's going on.
Excellent, thank you. And so with that, I think we will transition to the meet and greet session. That is for the folks who have been invited for that. So if that's you, please stay on the call. And if it is not you, we really appreciate your time and attention and hope that you learned something from this lecture. I know that I certainly did.
Thank you, Jennifer.
Okay, I think we are good.
Yeah, you're good.
Okay, well, Jennifer, so we have here, so this is a very informal session, Bruce, and I think we have invited two of our faculty, or we have three of our faculty here. So we have Shalene Perez.